very short introduction and welcome everybody to another question and answer session with the PBC Foundation.
Thank you, Alan.
Collette, our Chief Executive Officer. And this week we're absolutely delighted to welcome from California in the US, Dr. Robert Gish. So I'm sure you will have a very interesting and informative session, and I will catch up with you near the end.
Thank you, Alan.
Thank you
very, very much. Hello, everybody. Good afternoon. You'll see that I'm not in my normal settings. I'm in my holiday home. So thank you for joining me on my holiday. I'm delighted Bob's with it. Now, Bob, do you prefer Bob or Robert?
Let's see. This is an odd day of the month, so Bob is good today.
Bob's good today. Okay, Bob, thank you so much for joining us. Now, just first of all, before we go into this session today, I want to thank you hugely for all the support you've given the PBC Foundation and its members. I know you were involved in International PBC Day this year and, of course, previous. And as we spoke about earlier, we met some 5 years ago, everybody, and he carried my dog because she'd little legs and we were walking a long way. And we've had a lovely relationship with you. Thank you for everything you do. So please take that on board. So welcome here today. And now, before we start off the questions, Bob, are you happy to tell our people a bit about yourself?
Great, Collette. Thanks a lot. And thanks to Alan for arranging all this. Yes, I am based in San Diego, and I have a network of clinics throughout California and Nevada where I see patients. Over the last year and a half, of course, it's been mostly by telemedicine, but I'm starting to travel more and see people in person. Mm-hmm. And I teach in Reno and Las Vegas at the University of Nevada, and also have patients around the Bay Area, Santa Rosa, San Jose, Folsom, California. I have a clinic in San Diego. I work with Loma Linda and their liver transplant program. I also have a number of tumor boards that I'm on. I deal a lot with liver cancer and a lot of research. These are some of the activities I have. I also work in drug development for different disease states. I'm on a safety monitoring board for Simibai, one of the PBC companies that has Seladelpar that's in development. So monitoring the trial and keeping things safe for patients, as well as looking for effective new medicines. That's just a little bit of a taste of what I do. Of course, PBC is a big part of my practice and focus. And in fact, I was on a call yesterday with the Simibai people, and I'm hoping to go and visit them. They're in Newark, they're in the Bay Area. Work and consult with Intercept, and I've been taking care of PBC patients for my whole career, which now dates back 30 years. I think that's a short description, but thanks for having me.
You're welcome. You do an awful lot of work and an awful lot of things for PBC patients. Now tell me, are you all using OCA in the States? OCA?
Yes. I've treated over 70 patients with OCA, Ocaliva, obeticholic acid. We'll kind of alternate the different names. So I have a very big experience.
Okay. Good. Right. Our first question is in that region. So someone has said that the ALP seems to be up 167. It's never down, although they've been on nursery for 2 years. What do you suggest? Somebody's saying, am I too late to ask a question? Type it in, Jane, and let's see what we can do, okay?
And if I could, Collette, I'd like to start off with just a general terminology, how we talk the language of liver tests.
Yeah.
A lot of patients, and much more often providers, I'll use the word providers because it could be doctors or nurse practitioners, nurses, pharmacists.
Yeah.
They use this word liver function test just in general. Every time I hear that, I have like some hair that kind of goes up on the back of my neck a little bit. I really want people to use the term liver enzymes separate from liver function.
Right. Okay.
Alkaline phosphatase is a liver enzyme. It's not a liver function test.
Okay.
GGT, which I like as much as I like alkaline phosphatase, should be done on everybody with liver disease. Then AST and ALT. So that's the packet of four enzymes.
Yeah.
And bilirubin is my favorite liver function test. And
okay.
a new break for this too, because whenever I have a bilirubin that's anything greater than 0.7, and I think your audience is sophisticated here, if it's above 0.7, the bilirubin should be fractionated. It should be digested or be split into direct and indirect.
Yeah.
Because the direct bilirubin, do you agree, Collette, is the best liver function test? Great. So we're on the same page. And then, of course,
Thank you for that.
So alkaline phosphatase, of course, is the kind of the top of the pyramid for monitoring PBC patients. And really the goal with alkaline phosphatase is to be normal. And I have a question for you, Collette. Have you discussed with your group the difference between normal and healthy?
No, but I would like to hear more about it.
Okay. So when the laboratory says a test is normal, they've usually established in 100 patients or 200 patients what people they think are healthy, what the normal range might be. So alkaline phosphatase could be 40 to 115. That's sort of the typical range. But if you take people who are healthy, they have a normal weight, they don't drink alcohol, they don't have fatty liver, they don't have viral hepatitis, they don't have PBC, they really are healthy, really healthy. I believe a normal, healthy alkaline phosphatase should be about 85. We have a paper that brought up this idea that we published last year with one of my colleagues. I can share that with you. So 115 is kind of the door to talking about normal, and below 100, maybe below 90 is really where we're going to talk about healthy. So alkaline phosphatase should be normal on therapy if we can get there, but 117, 137, 140 is much better than 300, which is much better than 500. So every decrement, every amount of decrease of alkaline phosphatase means a lot. And getting to normal, maybe that should be a banner for something. It's getting to normal. How do we get to normal? So that's an intro thought. I have more, but I'll stop there, Collette. Am I going the right direction?
You're going the right direction, but we've got very little information. And so I would say to this person, they don't say if they've been invited to take Ocaliva or whatever you're calling it, but they don't say if other therapies have been suggested, because people are given BC5 rates as well in this country. So, and I don't even know if they're from this country. So it's very difficult to answer this in full. But really, I suppose, would we agree, Bob, that at an alkaline phosphatase at 167, this person should be asking their physician, what's next? What can they have?
I think that's the perfect question. And Collette, has your organization on these calls or otherwise talked about other ways to look at liver health, such as FibroScan or some of the blood tests that we have?
Yeah, but you don't always get these information with the questions, of course, and people sort of zoom in on something that's they know isn't normal, and that's the little bit of information that you get, you see. But yes, you're absolutely quite right in what you're saying, because FibroScan or the ELF test in some cases is quite important information as well, isn't it?
Yeah, we're expecting the ELF test to be available in the U.S. in the next few months, and that's I think that is an exciting test. And
excellent.
But almost everybody in the world, I mean, there are some low-income countries that may be limited, but an abdominal ultrasound really can tell us a lot about the liver condition. And when I get an abdominal ultrasound, I always ask the radiologist to measure the spleen. How big is the spleen? Yeah. And how wide is the portal vein? Has that been discussed?
Yes, it does. It does come up. And of course, everybody does different things in the centres around the country, don't they? And not everybody gets to see a specialist, somebody who knows PBC inside out, somebody like yourself who's been working on it for years. And that's where we come in, Bob. We can help people, on their journey and give information, get people to ask the appropriate questions.
All right, so the question here is a discussion about Ocaliva. The question here is, what's the stage of the liver disease by blood tests or by imaging? And if somebody is 167, I'll just give you a general number, and their ultrasound is normal, their FibroScan is normal, their AST and ALT are normal, their platelet count is high, not high, but normal, say 250,000, I would be less aggressive about that person than an ALK phos of 167 and the platelet count's 140,000. Have you talked about platelet count and how to use that to talk to patients?
Well, no, we don't cover. Well, we will if we're asked to, but it's not something we do normally. Normally, that comes in when somebody's talking about further advanced PBC, but it does come up when needed. Yeah.
Great. I think platelets is a very, very inexpensive way to help talk about liver disease stage.
All right. Okay.
I can give you a couple numbers there. Shall I do that?
Yeah, go on.
Okay, so a healthy platelet count is over 200,000, usually between 200 and 300,000. Once the platelet count gets to about 170,000, that makes me strongly suspicious that they're at this fibrosis level 3. And fibrosis level 3 is just before cirrhosis. And if the platelet count is getting towards 100,000 or below, that person has cirrhosis. So everybody has a CBC and everybody has a platelet count in their chart, probably wherever they may be in the world. And my eyes go to the ALP phos first, they go to the platelet count second. And it's just a fast way, starting to get a direction or an assessment of where a patient might be.
Okay, thank you. I'm going to move on because we've got a lot here, Bob, if that's okay. But we would suggest this person to go back to your specialist and ask them what there is available, would it be beta fibrate or OCA. The next question is from somebody who's 60 years old, young, and been diagnosed 3 years with very little fibrosis, which is it's not an exact measurement. Now, this is a very good question. How can I manage overwhelm and fatigue? Not overweight. They're on Urso-1 OCA. She likes dancing a couple of times a month. She walks her dogs. She has a good diet and keeps hydrated. She sleeps a lot, and she's doing housework as a job of work, which is really quite heavy going. Now, I'm going to firstly say to this well done you, because everything you're doing is fantastic, particularly the movement, and you've got a very, very heavy manual job. But any change, anything different, or anything exacerbated or worse, always get it checked out, because we get other things too. We get thyroid disease, we get all sorts of, not even autoimmune conditions. We're normal. Well, as normal as we can be. We get other things. So I would say to this person, well done you, looking after yourself so well. You know, we would like to know more about you, and we can tell others how it's done. But I am a wee bit concerned that maybe there's something else going on, but I'm not a doctor, Bob.
Yeah, I think, you know, just getting a thorough medical workup is very, very important. As you mentioned, thyroid's super common. I also work up every one of my PBC patients, or at least assess them for the chance that they might have celiac sprue or wheat allergy. And that can be done with blood tests. Occasionally it requires an endoscopy with a biopsy. So wheat allergy, wheat sensitivity, sprue would also be on my short list. And everybody needs an eye exam every year, because dry eyes and dry mouth and dental hygiene and dental health is very important for general health. If you have a lot of inflammation in your mouth, that could lead to feeling poorly and more of a systemic inflammation, more of your body having inflammation. So everybody's got to be really good about taking care of their teeth.
That's a very good point, because as you know, we get Sika syndrome, Sjogren's syndrome, etc. And I would say to people, one of the best antiseptics is salted water. My granny told me, and my granny was right about everything. And I know this because she told me. So salted water, be very mindful of these chemical mouthwashes you can buy over the counter in chemists, because a dentist will tell you they can distort your taste, they can kill off good things in your mouth, and they can also discolor your teeth. So good hygiene, you know, flossing and what have you, and salted water. But I do think this person should go and just get checked out. We've got, this is from Canada, and this lady was 62 when she was transplanted. Oh, she is 62. She was transplanted in 2012. And her PBC has come back. She's on Urso. Now, she's had helicopter pylori. So she had to come off Urso for a couple of weeks, and then she went back on it again. But when she started up again, her ALP was 196, AST 44, the bilirubin was fine. Has the URSO stopped working, or has the PBC, or is the PBC progressing? Helicobacter pylori, that's what I was trying to say, which is a great story in itself, by the way. So there we are. Did you get all that?
Sure. One of the things I would always think about is the antibiotics that people use for Helicobacter can cause liver enzymes to change. So, and I never just look at one panel of liver enzymes or look at one alkaline phosphatase that say things are worse or better. It's always about trends over time. So in general, if something gets changed, somebody gets an antibiotic, somebody's off URSO for a week or a month, they basically should be having their liver test checked over the next couple of months, and then decide if there's progression or lack of response or relapse, recrudescence. So don't look at just one test, look over time.
A trend.
Yeah, change. Trajectory, the direction, right? That it might be going.
Yeah.
I think those are important ideas. Is that a good answer, you think?
Yeah, that's an excellent answer. But I love the whole Helicobacter pylori story in itself. I just, that's medicine for you. So yes, indeed. So that's one to keep an eye on. And they've got great PBC specialists in Canada. We know this, don't we? One of them's particularly handsome, but that's got nothing to do with anything.
Some of the best in the world.
Okay, so somebody's taking metformin for polycystic ovary syndrome and stopped when she was pregnant. So after childbirth, she can't get a straight answer from her GP or consultant if she can take it again. It does help her control her weight, which she was gaining with her. So I don't know where this person comes from. If you are a British person and you've put this question in, I would urge you to contact me at the office, because somebody somewhere has got an answer for you. So we have to help you find that person. But Bob, I'd appreciate any thoughts that you have.
So metformin is really where I'll focus the discussion, if that's okay, Collette.
Yes, of course.
So we have an epidemic of metabolic syndrome in the world, and metabolic syndrome is commonly accompanied by diabetes and rarely polycystic ovary syndrome. But it is part of the metabolic syndrome in general. Metformin is a first-line therapy for treating this metabolic syndrome, especially diabetes, but it's probably protective or helpful even in pre-diabetics, which is where it's used also, and in PCO. It's very safe. And in fact, we think metformin is one of those medications like statins that are actually liver protective. And there's data that metformin may decrease the risk of people getting liver cancer. So metformin is a liver protective medication. It's been around for 30 years. Safety profile is excellent. The only catch or caveat or thing I think about is people with kidney dysfunction. So if somebody's kidney are off, they really should talk to their provider about dosing or stopping metformin at a certain level. So that's really the safety discussion with metformin. I think it's very safe, but definitely go back to your specialist to discuss further.
Very interesting. Oh, it's really nice speaking to you today, Bob. I'm learning lots of things. We've got a wee message here from Mona. Good morning, Collette, Dr. Gish, and everyone from Louisiana, USA. Thank you for being there today, Mona. You're very, very welcome indeed. Right. Okay. Let's see if I can get this one right for you, Bob. So this person was tested positive with AMA and M2, AMA, M2, and ANA. ACH11 and 12, blood work normal. Blood work leads me to think this person is maybe American. Mother had PBC and died of cirrhosis. She has symptoms of bone and muscle pain, itching, nausea. Referred to a liver specialist and rheumatologist, but it's taking forever for an appointment. As confused as I have PBC with do I have PBC with more normal blood? If you've been on URSO and you've got normal LFTs and AMA negative, does this mean no longer PBC? Can it be cured? I can only answer one of the questions, no. At the moment is the rider, okay? Well, Bob.
So are we going to mention something I've learned from Cynthia Levy and some of our other great PBC colleagues is that AMA can have a false positive. So the AMA test has changed over the last 15 or 20 years. It's good because it's become more sensitive, which means it's picking up more people who have PBC or are at risk for PBC. Just because a positive AMA and you do a liver biopsy on everybody, some people may have a normal liver biopsy and you say, oh, there's no disease, but they might develop PBC in the future. So I'm going to say 100 people who have a positive AMA, probably close to 90 will have PBC. 5 out of 100 will never develop PBC. They just have a positive AMA, and we call that a false positive. I don't know if it's really false, but just they didn't evolve. Another 5% don't have it currently, but need to be monitored and may develop it in 2, 5, 10 years. That's kind of a simple rule. Collette, what do you think about those numbers?
So she needs to just go back every so often, keep an eye on that. Yeah.
That's
and the fact that her mum had cirrhosis, PBC
Yes.
anyway. Okay, so we have a male. So we've got a male who quickly needed a transplant as he had aggressive disease, which we do see from time to time, not that often, thankfully. And the question is still, do I still have PBC? He has ischemic cholangiopathy, which is not curable, and they say he'll need another transplant. He's back on Earth, so happily, blood's good after 7 years. So do I still have PBC? I don't know that we can answer that, Bob. Or what do you think?
In general, we say that people who go to transplant with PBC have a recurrence risk in that new organ that's in the 20+% range. Some numbers have been higher than that. There was I think there was a publication that came out in the last couple of months, a meta-analysis, which is where they put a lot of studies together that gave those types of numbers. So yes, it can come back. Whether it comes back in an individual patient, it really has to be, I think, determined by liver biopsy. And in this case, if you've got another liver disease, such as ischemic cholangitis, that is going to dominate PBC. And you may not even see PBC on a liver biopsy if in a patient, they've got rejection, they've got ischemic cholangitis, they have some other problem in that liver, such as fatty liver, the PBC may be buried or hidden or not active. So I would say this person, just taking this as a general comment, to expand this to people that might be in this situation, is that they just work with their transplant center. Urso is a good drug for PBC, of course. It's also useful for this ischemic cholangitis, and just work with the center. And then I'd be focusing more on that second transplant. What's the right timing there?
Yeah. It's interesting. I've never heard of ischemic cholangiopathy. Ischemic heart disease, yes, but not cholangiopathy. So learn something today. Okay, so we have a newly diagnosed person here who started Urso just the other day. She's having her LFTs done in 3 months. Her expression, not mine. So she'll have her bloods done in 3 months. And then she's got an appointment to see a specialist in 6 months. So she says, if marked symptoms, example, fatigue or adverse reaction to medications, who do I contact, primary or secondary care? I'm assuming that this person is British. I would advise you very strongly for any of those things to contact your consultant by email. You know, don't be wasting your time on phone calls, leaving messages with secretaries. Email your consultant direct. And if you can, let your GP see a copy of the email and any response. They're also asking, I think they are British, she's been given Urso and just 1 month's supply. Is that normal, given it's a lifetime drug? And no, you can't receive them, because I think you're in England, and in England you pay for your prescriptions. In Scotland you don't, Bob, or Wales we don't. So you can ask for 3 months supply. Is there anything you would want to add to that, Bob?
No, I think those are all good points. It is typical to check the liver tests every 3 months. That's very, very common. We don't really check monthly unless there's something really concerning going on. And then make assessment at 3 and 6 months. What's happening? What's the trajectory? We were talking about that before. What's the change? How much the alkaline phosphatase and other liver enzymes have changed? And of course, function, follow your bilirubin, total bilirubin, direct bilirubin, ask those questions and make sure you're separating with your provider the difference between enzymes and function. Don't put them all in one basket.
And I think it's important as well to remember, things have changed from the old days with doctors when doctors were God. It's okay to ask questions. It's okay to say, I don't understand. Or could you put that in a way that would be more helpful to me because I don't understand some of these medical expressions and terms? I think, Bob, it's important we try and give people confidence to speak with their doctors. Do you feel in the States that there's a bit apprehension about speaking to medics and specialists?
It's much less, Collette, than it was 5, 10, and 15 years ago.
Oh, that's good.
The doors are open, telemedicine, email. But some providers don't give their emails out. Some providers don't give their cell phones out. Others are wide open with me. Everybody's got my email. Everybody has my mobile number. Mm-hmm. Patients are amazingly respectful. I mean, I might get 3 texts a week from patients, and it's usually something urgent or concerning. Yeah. So let's open the doors wider. We can train the providers to keep their doors open, right?
Great. I was hearing from a specialist, a hepatologist, who worked with George Mills in Cambridge, and she's Scottish. She's come back to Scotland, and she's noticed Scottish people are quite reticent to talk and ask questions. And it's a case of, I'm 60 now, I've had a good life. But she's saying, well, no, actually, we can do a lot more for you. But she noticed a difference in the 2 adjoining nations, which was quite interesting. Now, I'm going to come to the screen now, Bob, because I am going to confess to you, I'm not sure how to pronounce some of these names. So it's from Jane. And she says, I have famotidine, I think, and 2 other drugs. Can I take them all together, or do I need to take them separately? Can you see that?
Yeah, I do. And I think this question about medicines, taking them together, taking them separately, needs to be individualized for each patient. In general, medicines can be taken at the same time, but there are drug-drug interactions. And I always go either to a pharmacist or go on the internet and look and see if there's an interaction between the different medications. Yeah. So this is really something that it has to be individualized and talk to your provider about. I'm giving you some general ideas that I think generally it's safe, but let's individualize.
Absolutely, because we don't know what else this lady's on. But the other thing, you raised a good point about pharmacists. Pharmacists are highly qualified people, and I think they're a wee bit underused, if I may say. So you raise a very good point there. Right, so we've got this person saying, I'm on cholestyramine, or what's the other word for it? Quercetin, for a couple of months for my itch, and it works, but my eyes are so much drier. They were already dry, and I'm on something I can't read, but I'm using it for a lot more. Is there anything I can do to make them better? I am drinking water. Well, I'm not sure about drinking water in your eyes. I will say, I don't know where this person is. There's lots of different products on the market, and you can check with your optician. There's oil-based drops as well. And there's something, we call it Lacryloop, Bob, where you can put it in at night. It's a bit like Vaseline, and it's quite gunky, but it does help. What comments would you have, Bob?
Right. So every patient with PBC needs to have an eye exam at least once a year. I don't know if the PBC Foundation is recommending twice a year. And then
we actually don't recommend at all. So that's another point of yours I'm going to take up and run with it. So thank you.
Okay. And like you mentioned, there's a lot of different tear substitutes that are out that, of course, could help. Staying hydrated is very important, because when you get dehydrated, tear and saliva production goes down relatively early. Oh, I've been out in the heat. My mouth is dry. Well, your eyes are going to be dry too, just like your mouth, because the tear production will fall off. Mm-hmm. And then, of course, there are surgical procedures where they can, occlude the duct that drains the eye to keep more tears in the eye. Mm-hmm. We really don't have too many medicines that increase tear production. There are a few, I don't remember the name, but there are some medicines that do protect the eye if you have severe degeneration of the eye itself, and that's to be worked with. In the US, I really would go to an MD ophthalmologist, although optometrists, if they're sophisticated, could also help with this.
Mm-hmm. Thank you. And I think it's worth saying as well, it is a problem as you get older anyway. It's not just peculiar to people with PBC. I can assure you I've got both. I'm getting older and I've got PBC. So someone's saying here the bilirubin is up again, 34/01/09 and 54. Oh no, that's the date. So it was 34 on the 1st of September and it was 54 on the 20th September. And there's something else that says also my child Pew has increased from A to B9. I actually don't understand the second part of that question, but the bilirubin I think is significant. Bob.
So this is really important about liver function. And when you hear these numbers this big, it typically means that they're in millimole units, not milligrams. In the US, we use milligrams.
Right. Okay. Yeah.
In Scotland, Great Britain is going to be millimoles. And 16 or less is considered normal. Mm-hmm. And then the direct should be about 5 or 6 millimoles for the direct bilirubin. So I would always want this bilirubin fractionated, and I'd look much more at the direct bilirubin. But these numbers going up, and what the child puke question would suggest to a provider and a patient that they have cirrhosis, and they're leading into decompensated disease. Decompensated is a fancy word for the liver's not working as well. And this person definitely needs to be in the hands of a specialist. Specialist means GI, liver, hepatology, and there should be a discussion about when's the right time to talk to a transplant center. So these are really important comments. That bilirubin number and its change is imparting something serious. Typically, we would talk to patients about recent imaging to look at the liver. We do surveillance for liver cancer in PBC patients with cirrhosis. They can also get gallstones, they can get obstruction. So we really need to know what an imaging would show in somebody with a changing bilirubin.
Yeah, and then this has gone up quite quickly. So this is a now task for whoever sent in the question. Child Pew, that's new to me, Bob.
Okay. So the old score we used for liver disease was developed by a man named Child. He's not a children, but his name is Child. And then there was another surgeon named Pew, and another surgeon named Turcotte. And these surgeons were working with cirrhosis patients and having to do bypasses and shunts. And they came up with this score, the CTP score, or CPT score, to say who is going to be at higher risk of complications after surgery, maybe even dying after surgery. So this dates back into the 60s and 70s, actually. And it's a mixture of 5 tests: albumin, which is a liver function test; bilirubin, another liver function test; INR, or ProTime, that's another liver function test. And then they do a physical exam and see if they have ascites, which is this fluid on the belly, and then encephalopathy, which is a change in mental condition. And they score it from 5 to 15. So a child's A goes up to 6, and then a 7 to 10, 7, 8, 9 is B. And once you get to a 10, you are a C. So those ABCs and what the numbers are all imply how serious the liver disease is. So this is an example that to teach everybody. The child score is going up, the CTP score is going up. You're going from an A to a B. That liver's getting worse. Need close follow-up with a specialist. Need to be talking potentially to a transplant center.
Okay, that's interesting. Thank you. I'll bear that in mind. Now, I've got another question here. I'm not sure I understand it, but I'll give you what I think my understanding is, and I'll appreciate your thoughts and comments, Bob. Many thanks for the interesting information. How is the control of PBC patient post-COVID infection? Sometimes it's very difficult to top up these patients. Now, I don't understand the second comment, but how is the control of PBC patient post-COVID infection? Everywhere in the world are having difficulties, and there's a lot of online consultations or phone consultations. Some patients like that because they feel vulnerable going to hospitals, because hospitals are considered hotspots for COVID. But in this country, in the UK, they're getting through it. If you feel you've not been seen, you would like to be seen, or you feel you've dropped in between two stools, email your consultant or write a letter. Don't sit and wait. Just proact. Bob, have you got a comment you'd like to make on that?
Yes, telemedicine, phone medicine has really changed the medical world dramatically, which I think is fantastic. But it's back to what Collette, you were talking about before, is the patient being proactive with their provider and telling the provider what they need. Do they need a physical? They need a face-to-face meeting. They need to know their lab results. They need better communication. Patients should be very clear as to what they want, what they need for better care. And these are all reasonable requests. Now, of course, if someone's contacting their provider every day by email, that's way too much. So save your questions, send them in little groups, maybe once a week. But yes, make it clear you want a physical exam. You want to be seen in person. You want that face-to-face time. And things are getting better. I know that in Great Britain and Scotland, England, things are getting better, like the US. People are going back to the offices. They're seeing people. But I think telemedicine, I hope, I'm projecting, it's still going to be 60 to 70% of our care will be over telemedicine. I think it's better care. You know, if you're tired with PBC, you have to get in a car, get on the freeway, go drive an hour, go park, wait another hour for a 15-minute appointment, and have to reverse everything. That's 5 hours out of your day for a short interaction with your provider, which if you're more awake and not tired, that 15 minutes over telemedicine could be much better value for you. So think about what you need.
Yeah, and it works for some people and not for others. And there isn't a right or a wrong. It's just whatever suits you. But what I would say to you, if you do have a tele appointment or a face-to-face appointment, be ready with a bit of information. Have a list of your medications and doses at the ready. There's no point in saying, oh, I take that little blue pill. What do you call it again? Have your list ready, because that's time. You know, you want as much time spent on you and not trying to figure out other things. So have a list of your medication ready. And also any changes from your last visit or consultation with your specialist, any changes, when they happen, how often it's been happening, or how much it's troubling you. And if you've got any worries, that's your opportunity to ask. And it may well be nothing, but that's okay to ask. Nothing's fine.
Yes.
I think that's reasonable, Bob, would you say?
Great advice, Collette. Fantastic.
I've had PBC a long time, Bob. You know this. 27 years.
And you look great.
Thank you. So here we are. So I've been on calciamine 4 milligrams 2 times a day and I've been doing okay. They've stopped using it in the NHS and they're giving me Quercetin. Well, I thought they were the same thing, which causes my eyelids to swell up. And then tried Holstead, which made my itch return. And then gave me pins and needles in my hands. What else can I take? There's actually quite a few things out there for the itch, isn't there, Bob?
You know, this is a really good point, because remember we were talking before about famotidine and antibiotics potentially, and having drug-drug interactions. And that those classes of drugs don't have a lot of drug-drug interactions, but they're there. But cholestyramine, cholesterol, there's a whole class of these bile acid binding resins. They're similar. They're under different brand names. They have slightly different formulations, but they do bind drugs. They do bind other prescription medicines. And digoxin's an example where it might bind it, or magnesium, a metal, or something else. So these classes of drugs, these binding resins, you need to really talk about drug-drug interactions, and definitely don't take cholestyramine or cholesterol, this group, with your URSO or with your OCA, because it will bind that and decrease absorption, because that's the purpose of this, is to bind bile acids and other toxic intermediates. So these compounds have a little bit of different formulations. So they might have a coloration agent or something to stabilize it that could result in an allergic reaction. So if you change medicine and your eyes swell up, it's probably an allergy. It's probably an allergy to some component, not necessarily the resin. And they need to switch back or switch to a third agent in this group. I personally don't use these binding resins very much, Collette. There's kind of a difference between what I do and what all these recommendations are, because a lot of my patients dislike, eating beach sand every day, 2 or 3 times a day.
A wallpaper paste, I've heard it called, yeah.
So it's, I start with other medicines. I usually start with Atarax, and I really like Primrose Oil, which is an over-the-counter extract from this.
Well, tell us about Primrose Oil. How would you take that?
It's oral. I mean, you don't put it on your skin. You take it as a capsule. It's 1 or 2 grams twice a day. It's an extract from these beautiful flowers, and it contains a derivative of lysophosphatidic acid, phosphatidylinositols. And these counteract some of the itching mechanisms that we don't fully understand, but it works and it's natural. People like natural things. So Atarax, Primrose Oil are my starting points. And then I've got another list of 14 different medicines. And the bile acid binding resins are really in my second level of treatment. Am I doing the wrong thing, Collette?
Nope. No, at all. What I know, that's really interesting, because I don't know any doctors in the UK that will comment on non-medicated drugs, things like Primrose Oil. So I must pass that down the line. I was asked by James Newberg to give him any tips you were giving us, right? So I'll speak to him.
I'll tell you one more. I had a patient who came in and said, dandelion root is something that's sold over the counter in the United States.
Yeah.
They had a fantastic response to dandelion root. So it was another one.
And do you use things like Rifampicin, which is used for for TB, isn't it? Tuberculosis. Do you use things like that too?
Yes. That's sort of second to third level. It's a little bit more aggressive. It has some liver toxicity risk in and of itself. But it works, absolutely. So it's down the list, but it's on the list. And I always tell patients with itch, they try medicine, they wait a week. If it's not working, you try something else. This isn't something be miserable for a month until your next appointment. Have a way to communicate by phone, or have a checklist, or have like a little diagram. We're going to go A, B, C, D. We're going to move quickly, because people should be comfortable as quickly as possible. We shouldn't wait 1 month to make another change.
That's a very good point you raised. And I would also say to people, we have the PBC app, and in the PBC app, we've got a questionnaire running at the moment about the itch. Pharma researchers, they want to hear how it is for you. Now, if you don't itch, great, but fill in the questionnaire. If your itch is treated reasonably successfully, very successfully, or nothing's working, let us know, because we need statistics, we need data, and this is for the pharma and researchers. They need to know what it is that matters to us, and the itch is such a major debilitating symptom for many people.
On my website, Collette, there's a sheet. It's my checklist. I post there, and people can download that. That's something you may want to talk to your advisors about. You want to have a link to your website or post it there. Of course, people can rearrange the sequence. Also, one comment on Atarax that I learned from one of my colleagues in Texas, who's a psychiatrist, who works with PBC patients, is that Atarax at higher doses can change the way the heart rhythm works. So I always get an EKG on my PBC patients and check something called a QTC. QTC it's really a number that says how is the electricity going in the heart. And if that QTC is long, we have to be a little bit more careful, not just about using Atarax or hydroxyzine, but some of the other itch medicines there. So every PBC patient should have an EKG in their chart to assess their cardiac health and look at this QTC if they're really getting on a lot of complicated medicines.
Very, very interesting what you say. This may be interesting or not, but we have quite a few people that newer diagnosed people. Some have it a bit more advanced than others, who are very interested in self-care, diet, exercise, and everything else. And there's a few stories I've been hearing now of people just changing what they eat, the way they eat, and it's had a positive effect on the itch, which I find very interesting. And I'm hearing things, for example, I gave up chocolate. I mean, it's not something I'm keen on. Give up chocolate. She went, and her itch stopped. She didn't make a connection. Come Christmas, she thought she'd have a treat. Ate the chocolate. The itch came back. Now, I should think everybody should look at what they are eating and how much of it. And would you not say so?
I can't eat chocolate because if I eat chocolate, my skin breaks out.
Is that real? I hate the stuff. It just would make me violently ill. But I know that we're rare. You and I are totally rare. Isn't that interesting? So, and is it the cocoa, or do you know what it is in the chocolate?
I don't know, but I thought I'd back up to general comment about diet. So a lot of people, especially in the Western part of the world, are on a heavy meat diet, red meat diet, which is really an oxidative diet. It's, causes oxidation of the body. And we really want to be on a reductive type diet, an anti-inflammatory diet. So I recommend all my liver patients really to shift towards fish and a vegetarian diet. My fatty liver patients, my PBC patients, really should get away from a red meat diet. Red meat should be there only for flavoring. It really should not be a focus. Fish, vegetables, a little bit of chicken, a little bit of pork, if religion allows that, is also okay. But get away from red meat, you'll see a big difference. And vegetables are fantastic.
Very interesting. Because people my age group, that's what they were brought up on, is red meat, is the big changes. And as for chicken, I was saying this to one of the doctors the other day. I don't think chicken used to taste the way it did in the old days. I don't know what they do with it these days, but it used to be an absolute feast. It was a luxury. Whereas now I find it quite unpalatable.
If you want to decide not to eat chicken, watch a movie called Food Inc. And
right.
that movie will make you a vegetarian.
Okay, most of my food is vegetarian. So some says, Bob, have you had any patients that have found success with nutrition response testing?
What bovine? I'm sorry?
Bob, have you had any patients that have found success with nutrition response testing?
Yeah, I'm not sure of the word. Can you spell it for me?
Nutrition.
Right.
Nutrition. Nutrition. Food nutrition.
Right. I thought there was another word, Collette, you said after that, but
no, nutrition response testing.
Okay. So every one of my patients, I try to get to see a nutritionist. I think that's a really important consultant process to take place. We talked about this team with a pharmacist and our nurses and other people. So nutrition consult. Naturopaths are somebody that are really big in the US. Do you have naturopaths in Scotland?
Similar. We don't call them that, but yeah.
So sometimes they get a little carried away with their supplement prescription, which really doesn't have much science behind it or has weak science. But the naturopaths are fantastic about diet and how to manage diet correctly. And they're sometimes even better than a straight dietitian or nutritionist. So I really like the naturopath route also. And they may find supplements or nutritional supplements that may help with the itching as well. So I think that's a resource to think about.
Yeah, we call them something different, but none of the doctors in the UK will really comment because much of what's being sold over the counter has not been trialed and tested, you see, and in a medical laboratory. So that's the reticence to comment. Now, there's something's come up on the screen from Lindsay, Bob. She says, "Hi there, I was taking liposomal glutathione before I was diagnosed with PBC. Is this something I continue to take? Thanks." I don't know what that is.
So glutathione is a combination amino acid that has sulfur in it, and it's a really powerful antioxidant. And we use something similar to glutathione to treat Tylenol overdoses. It's called N-acetylcysteine, and they're related. They're not the same. But glutathione is something that protects us from injury or protects our liver. What we don't know is if you take a glutathione supplement, how much gets to the liver and how much protection there is from the glutathione. We haven't really figured that out yet. I will say one thing is, I don't think it will hurt anybody to take this substance. It's not toxic and it might be protective. But if you're spending a lot of money and it's not helping with your fatigue or helping with your itch or helping with liver tests, liver function or liver enzymes, don't waste your money on it. So work collaboratively with your provider And, you know, in the US, we have a $60 billion industry of these supplements, over the counter, naturopath, traditional Chinese medicine, $60 billion. It's huge. And half the patients who come in are on something. And often they don't tell the providers they're on something because they're afraid of being rejected. They're afraid that they're going to be punished or admonished or in some way criticized for taking these supplements. So we really, as providers, need to be super open, let it in. We want the information. We don't get critical of some of our alternative providers that are out there. We just listen and advise people about safety. And also we can be a little critical and say there's not much data, but also if it's safe and the patient feels better, then that's helping.
Yeah, James Newberger always raises the point, well, if you think these things are harmless, take senna, for example. You know, overdosing on it can cause you problems. She's saying thank you, you're more than welcome. Now, there is something, Bob, I would like to raise. We're in the middle or the end of a COVID pandemic. COVID is a big issue. And as you know, vaccines are an issue as well. Now, our medical advisory are very keen that people with PBC have their vaccine. I don't know what it's like in the States. We have anti-vaxxers here. I heard in Edinburgh this morning that the people who are in hospital seriously ill with COVID and on oxygen, etc., are people who have not been vaccinated. So I really, if you wouldn't mind, give us a few moments of your thoughts about vaccines, COVID and PBC, etc., because I think this is really important.
I mean, the first comment is everybody in the world should be vaccinated for this. It's the only way to stop the pandemic. Everything else we're doing helps with masking, social distancing, some of the other restrictive events, but the vaccine and changes in human behavior are going to help stop this pandemic, just like we stopped the 1918 flu. Eventually, it took 3.5 years to get that under control. And the way we've stopped subsequent flu epidemics is because we're vaccinating people every year. The vaccines are as essential as plumbing in your house or fire to warm your house with your furnace. Vaccines are one of the, I'd say, the 4 or 5 foundations of human society. And don't reject vaccines. I tell people if they reject vaccines, then they should get rid of the plumbing in their house, not get in a car, and don't even use fire. You know, stay warm using a blanket. So in PBC, these patients are immune suppressed or have altered immune systems, and they need vaccine protection even more. And if they get sick with COVID, they're likely to get more ill because of the underlying liver disease. So these are very, very important facts. These are extremely safe vaccines. The hospitals are not full of vaccine reaction patients. They're full of COVID infections. The chance of having a severe life-threatening reaction to a vaccine is about 1 in 10,000 patients. The chance of dying of COVID runs 3 to 5%, and the chance of having severe COVID is 20%. There's the benefit to risk of the vaccine is 1,000 to 10,000 to 1. There should be no discussion, no question, get vaccinated.
What I find troubling, me and others, that there's a particular doctor who was struck off in this country who lives in the States. And he was back over here with a microphone in his hand in the middle of London with other people talking about anti-vax and not taking the vaccine, given that he was struck off because of his history with research that didn't exist. And in the MMR, as it was then, it is quite troubling that people are taking this on board. And what I would quite like to do, Bob, via you, is encourage people to come and talk to us if they have reservations. They can write to us, they can email us. I'm sure you'd happily answer any questions. You've actually been quite strong in your convictions about what you've just said, which is really helpful. I would also go on to say, Bob, I think you're a bit younger than me, I must say, but my generation, and people have heard me say this before, you know, when I was a wee girl, I was given, I had the polio vaccine, I had diphtheria, TB, smallpox. It was a way of life, and it was very, very serious. As you know, these illnesses. I would go to school, and little Tommy Thompson wasn't there anymore. He was gone, and that's how severe these illnesses were. And so, I suppose my generation are used to it. But I hope people take on board what Bob is saying, that with PBC we are more vulnerable. That's really what you're saying. We need to protect ourselves. And it's not just about us, it's about our families as well, and our friends, and our examples to other people. I mean, I'm sitting here, I lecture everybody on movement is medicine and do what the information I'm getting. But I've had the vaccines. I've had, 2. And I was fine. And yes, I'm nervous about getting COVID and I'm doing everything to protect myself. But if you're sitting and worrying about it, talk to us. Give us a chance to talk you through it, to give you something to read perhaps, or some anecdotal evidence to listen to. Is that reasonable, Bob? I'm pleasing with people because it worries me.
And Collette, I went just a little bit too far when I said no questions, no discussion. I should be saying keep your questions on point, the discussions short, and roll up your sleeve and get vaccine. It's good to have an open door. It's good to have dialogue, but this is not something that should go on. And Collette, one of the things that really bothers me about these anti-vaxxers is I've investigated each one individually.
Oh, good.
Behind the scenes, they're raising money for whatever they want to put in their pockets. The pro-vaccine people, like myself, I have nothing to benefit personally. I want to benefit society. I want to benefit families. I want to benefit patients. I don't have any financial incentive to tell people to get vaccinated other than I want to make the world better, a world a better place. I think there's a song called that. So the anti-vaxxers have another agenda, and it's money going into their pocket. That's what really disturbs me about this. Mike Liddell, he's a pillow guy. He's, made money off pillows, and now he's making money off an anti-vaccine campaign. These people have another agenda, and it's either about power or money. It's not about protecting people or protecting societies. Vaccines are as foundational as plumbing, as fire, as wheels on the car. Without wheels, without fire, without plumbing, we're not a society. Without vaccines, we're not a functioning society.
Brilliant point that you raised. Thank you so much. I'm glad I asked. I didn't mean to warn you about it, and I forgot. But that is a very, very valid point, because money is behind an awful lot of things in this world, isn't it? I mean, David Jones, Professor Jones, his comment about vaccines and clean water are the best things that have happened to this world in the last 120 years. Thank you so much for that, Bob. That is a very sharp comment you made. I'm delighted that we can share that. Now, we've got Mona up here. She's on the screen. She's how about taking NAC and liposmal? I can't pronounce them. To every day is it safe. I heard doctors talk about all 3 of them. Can you read that, Bob, from Louisiana?
Yeah, it looks like it's Quercetin. So Quercetin should always be taken at a different time than whatever else that you're taking. And this is NAC, which is N-acetylcysteine. And then I think they said liposomal, but maybe lysosomal glutathione. And those are, in my opinion, safe. They may be beneficial. Just take them 2 to 4 hours off from taking Quercetin or cholestyramine or cholesterol.
Yeah. Keep everything away from these buggers, as we call them. Now, we've got a last question here from Jean. She says, I've been taking Quercetin. I do apologize. I'm waiting to see the optician. I sat in my glasses, so I'm not reading very well. I've been taking Quercetin for vascular problems, which has improved. Is it okay to take for PBC?
Is it Quercetin that we've been talking about as opposed to Quercetin?
Well, I think that's meant to be Quercetin. Would you take Quercetin for vascular reasons?
Not that I know of, but there is something that's pronounced similar to that called Quercetin that people take as a supplement. Yeah. And I think so is something that's safe to take. Right. I'm going to do just a quick web search.
Okay. How many screens have you got there, Bob?
Three screens. Oh, yeah. So they're talking about Quercetin. This is a plant flavonoid. And it's found in carrots, onions, green tea, apples, berries. So people take quercetin as an antioxidant also. Right. But the good news is there's no drug-drug interaction there that we worry about. And I think it's fine to take. So I apologize that it was off on the spelling there a little bit, but quercetin is safe.
Thank you. I didn't help there either, I can tell you. But I think that the most important thing, apart from all the medications about PBC, people keep up the movement as medicine. You're tired, don't sleep. Even walk around the block and come back. You're a big advocate of this. It was Mark Swain that convinced me many, many years ago. First, I thought he was mad, but I do believe what he's saying. And I know people benefit from the movement in medicine. You've made some interesting points about nutrition, Bob. I'm going to watch this again because this is all on record, everybody. This is going out PBC TV YouTube channel. And I might even ask you to write something for me, Bob, in the future at some point. There's one or two things I would like to chat with you about some other time, but we'll arrange a wee Zoom call between us. But in the meantime, I'm going to say a huge big thank you. I've really enjoyed today. I was a bit nervous about some of the American pronunciations, I must admit, but I know you'd forgive me, Bob. But I think, thank you for answering everybody's questions. It's been very, very interesting, and you've given us a completely different, I think, view on the more natural side of things. And here's our Alan. Alan, did you enjoy that? It's great, wasn't it?
I'm just putting my mic on. Awesome. Absolutely brilliant. So informative, so interesting. And I was watching the questions coming in, and just fabulous what we offer.
Yeah.
Really fantastic.
Thanks for having me.
It's been a pleasure having you on our Q&A webinar, Dr. Gish. Thank you most sincerely.
Or Bob to his friends, Bob. Thank you, everybody, for joining us. I know this, we'll give you the numbers in a couple of weeks. This will be watched hundreds and hundreds and hundreds of times, Bob, and there will be a big interest from our friends overseas because they like to hear from non-British people too. You mentioned Cynthia Levy. We had her on, and I think we've got Alan Bonder one week as well. So it's absolutely great. But Bob, thank you so much for your time. I know it's early morning there. You're going to have some breakfast now, or are you going to go out for a run, or what?
I'm ready for some spring rolls and for somebody to come and help fix my house.
Well, all the best to you. Thank you, everybody. Alan, thank you for hosting as well. And don't forget, everybody, you've got questions, come in next week with Dr. Bonder. And also, please don't forget to donate to us. We don't get any government funding. Please donate to the foundation. We need your funds to keep us going, okay? Bless you. Thank you. Bye.
Bye, everybody.